Hey everyone, welcome to another session of Virtual Global Spine Conference. It's a real honor to have Dr. Carlos Goulart here. Uh, Carlos is a dear friend of mine. I've known Carlos for, what do we know each other for? Probably about 10 years or so. Carlos did his medical school training in Brazil, and we were actually co-residents together at SUNY Upstate in Syracuse for a number of years before I became his boss as an attending, and now he's one of my first disciples. So Carlos is a complex spine surgeon. He's out at Duluth, Minnesota. He's an incredible surgeon. He's an even better guy, and really excited to hear about his experience using the robot and all the applications he's been utilizing it for the first couple of years in his practice.
Thank you, Mike. Really appreciate it. It's really nice to see you, and even though it's online, and I really like to give you guys credit for Virtual Global Spine. This was an amazing resource for me to transitioning from residency to practice. I used to, I just still try to watch these videos whenever I can. If I can't log in, I try to watch it on YouTube. And it's amazing that you guys still consistently every week have this going. I really give you guys credit for that. And thank you so much for inviting me to talk today. I was thinking about what to talk, and we were having a discussion about the robot, and it's somewhat new technology, and we implemented here in a setting that we are a level 1 trauma hospital, but in a kind of like a rural setting. So maybe it's interesting for someone to see how we went about incorporating this into our practice, and it's been really successful. But there are certainly some nuances to it. So I'll give you my perspective into how things work for me in the first 100 cases that I have done here. I don't have any significant disclosures for this talk. So I came here in summer 2022, and then I joined Essentia Health in Duluth, Minnesota. It was kind of part of this expansion project for the institution. They built a new hospital tower. Is the level 1 trauma center that serves the northern Minnesota region. Like I said, still kind of has a little bit of the rural feel. So the hospital wanted to kind of upgrade its imaging across all the specialties, and bring in more technology and more specialized surgery and minimally invasive surgery, that kind of stuff. And so the robot was introduced in our hospital in the fall 2022. That was shortly after I started. I felt it was too many new things at the same time. So I kind of started with just the regular open T-lifts and normal surgery that I learned in residency. I was collecting in my cases for the boards, and I joined two really great guys here, Dr. Turzik and Dr. Burrows. They both had been in practice for a few years, and we're very collaborative. So I learned a lot from them in my first couple years out in practice, and they were doing a lot of the minimally invasive stuff already, and they incorporated the robot before I did. And I think this was really essential for things to go smoothly, and they really embraced this. And Dr. Turzik is our busiest guy with the robot, and we have done together just a little over 300 cases as of last week, and I have done about 100 cases personally. And so we're 3 full-time surgeons here, and we have 2 casual surgeons that help us offset some of the trauma call, and they have done a couple of robot cases, but 99% is really incorporated into our elective practice. So I think some of the advantages that the robot has, there are many kind of selling points, let's say, with the robot, but I feel like for me, really this predictability of the planning, this time that you can spend to look at the scans carefully and plan your screws, optimize the feel of the pedicle, the length of your screws, and the way it is precise has been like the major difference, compared to just usual navigation, which you do have sort of built into the robot, the stealth station that you can use as your navigation. But I think the robot is really more than just fancy navigation. I know some people make the argument it's just a more expensive type of navigation. I feel like there is this added uh, um, advantage of the planning, and that really makes you pay attention and really optimizes what you're doing. And like I said, you can still have that visibility from the stealth integrated in it. Now we have done a lot of cases, obviously, so the workflow works very nicely for us. It really doesn't. It's not something that adds a significant amount of time, and it has been really safe for us too. I would say that I had actually went back to my cases and I found about three cases, three screws that were misplaced with a robot out of these 100 cases that I did. So this is, several hundred screws, and they are all lateral breaches. Um, Early in the adoption of the robot, we learned some things that I'll discuss here to mitigate that risk, and a handful of issues with registration. There are some technology glitches that still happen, like with any kind of technology. But it has been very safe. We didn't have any reoperations. Out of our 300 cases, we did have one nerve injury from an ATS screw. Those all tap screws, and we changed that workflow a little bit. Now we always tap with the robot, and especially if people have very cortical bone, and we'll go over a little bit of that skiving issue that is something that you really need to pay attention with the robot. These are some of the things that you can play around with the software during your planning. You don't always have to do all of this, but it's very nice if you're looking for more correction, how things are going to look. You can uh, use templates for cages, different lordosis, things like that. And I do like, especially for longer constructs, open cases, to really pay attention to the planning in terms of the rod. And this really does save you a lot of times that extra stress at the end of the case when you're tired and trying to figure out how to put those rods in. And the software does tell you when the range of motion of the tulip heads are exhausted. So you do pay a little bit more attention to this the placement of the screws, and you can optimize that alignment a little bit better.
Carlos, hey,
Yeah,
can you hear me? I just have a quick question for you about
I do.
planning. So I'm a bit old school with planning. We don't have a robot at UNC just yet, and I don't really utilize software planning a whole lot. I still kind of measure out all my screws, especially for the big deformities before the case. And I can tell you if I'm doing a 10 to pelvis or 6 to pelvis, it takes me a long time. It'll take me 35, 40 minutes to plan out a case, all my osteotomies and the screw lengths, the screw widths. Talk to us a little bit about kind of like what the time commitment is for planning a case with the robot. Is this something that you come in the same day of surgery, you sit down as they're intubating the patient, or is this something that you still have to commit a lot of time to?
Yeah, that's a great question, Mike. I think so. I'll touch a little bit on the workflow that I use, particularly. You have a couple of options in terms of registration for the robot. The vast majority of the cases, if it's an elective case that you're doing a minimally invasive fusion or something like that, I do get a CT on the day of the surgery. The patient comes in a little bit earlier, and we get that CT, we put into the robot, and then you have, more than enough time to plan. It's very quick to plan the screws in the robot. It has, once you add, and this has been getting better because the software is always learning, AI technology and all that. So you try to add the screws, and the robot does it the best to add in the right place, and then you're basically changing the plan accordingly. But if it is a longer case, like I know you do a lot of bigger deformity cases. We have been using the unit platform. I don't know if you're familiar with it, but pre-bend rods is something that you can do. It's an option. So I have used for I don't do a lot of these cases, but my T10 pelvis revision, I usually will get the Scoli films and throw into that platform, and that you can pre-plan your rods, and I think it's a nice tool. But it does take a little bit of time to learn how to use it, and then they send you like a pre-bend rod that is a little bit longer in case you need to cut it. And I don't know, it's just sometimes challenging, to bend those rods at the end of the case. But I feel like regardless, you're still gonna have to spend a significant amount of time paying attention to the plan and planning for your correction and all that stuff. I don't know. Are you familiar with that platform? Have you seen
Yeah,
that?
no,
Yeah.
I've used the custom rods,
Do
a
you like
handful
it,
of
by the way?
times.
Some people love it, some people hate it, but
So
it has been useful for me. I don't know.
I don't think that I've got enough data into the
Hmm.
system yet. Like it
Same.
hasn't gotten to know me very well. So I think that's
Hmm.
kind of the drawback with the way that I've used it.
Hmm.
I I it sounds weird. I actually enjoy contouring my own rods at the end of the case. You know, I just do. It's like I feel
Yeah.
like it's a skill that took me a really, really, really long time
Hmm.
to get. And I'm trying to teach my residents the same thing. It's kind of an art form, especially at the end of a
It
deformity.
is. Yeah.
When you're doing deformity, you're actually not trying to contour the rod to the shape of the patient's spine. You're trying to contour the rod to the shape that you want the patient's spine to be. So a lot of times
Hmm.
the rod looks nothing like the patient's spinal contour, until the very end of the case, until you finish your correction. So I
Hmm.
still haven't found a big utilization for it in my practice.
Hmm.
Where I could see it being very helpful is in cases of kind of some of these like bread and butter degen cases
Yeah.
where you just want to be able to drop a rod in, get out really
Hmm.
quickly. And I think with the advent of software technology, like what you're talking about now, you can pre-plan the position of all of your tulip heads, right? And
Yes.
that's really hard to do before
I think
surgery.
this
But
this
you
panoramic
can
view
do
of
that
the
though.
construct that you get, because you can basically use the software and put all your screws where you think that, is the most appropriate location and all that. But then at the end, you get that panoramic view, and sometimes you're like, oh, I don't think this looks perfect, and you move. It's not a lot of movement, and things can change considerably and make things a lot easier and more straightforward
Yeah,
without
I think if
compromising on the screw placement.
yeah, I think if you go all in with this technology, I'm sure it's incredible.
Hmm.
But like the way I've kind of utilized it is I'm kind of like half in, where
Yeah.
I've used it for some cases, I've used the custom rods for some cases, but I don't
Hmm.
have the robot yet. So I think if you go
Yeah.
all in, kind of like you're doing, I think it's an incredible tool.
Yeah, I think it's one of those things that it will get a lot better over time, and there's a lot of room for opportunity here to get better. But it's you know it's not completely there yet. So um, which is kind of one of the cool things about the robot. Everybody that it has been using it hasn't been using for a decade. It's very rare for people to be using this for many years. So there's a lot of variability in how people use the robot, and you can kind of personalize to your own needs too. Um, all right, so we move on here. So this, then same thing that we're talking to here, construct design. I like to use it this, you can see the markings here where the skin incision level is. And for me, this has been useful mostly for minimally invasive cases to minimize the size of the incisions and minimize tissue damage. And then there is the advanced, deformity planning that we're talking about, not something that I do a lot of work with. I know there are some guys out there that have been doing a lot of deformity corrections and using the robot. And I think there's still a lot of room for development there. So then, I watched my partners doing a lot of cases. I felt like I was more confident in my own skin, and then I was like, where do I start? So like I mentioned, there's a lot of variability in the usage and workflow of the robot, which is both a good thing and a bad thing. I feel like we do need to have in the future more standardization and maybe like best practice guidelines. I know that some large institutions with a lot of surgeons had issues, with people using the robot um, in ways that were not really uh, exactly correct, and then having complications, and then they develop best practice guidelines. So I think there's a lot of opportunity for education in this area, and collaboration is really key. Having before you start, if you can see people doing cases, discuss cases, because there's not a lot of pre-requirements. Your institution can get this as sort of like a great marketing thing, and then you have this, you do like a 2-hour course, they show you how to use it, and then you're on your own. And you're like, yeah, use it however you want it, but we got to be responsible with implementing these things. And the best thing is really learning from other people. Initially, you want to adhere to these limitations and the working distance, regarding the reference frames and where to put your bone fixation according to the manufacturer recommendations, which after you do you have done 20, 30 of these cases, you realize that you can't safely use the robot for more, but you don't want to be doing that right off the bat, and until you understand really well the technology, how the accuracy checks work and all that stuff. And the we were lucky here also to have very experienced reps, because we're close to where the company headquarters is, and so we had people that had a lot of experience with the robot to come here and help us implement this. But and over time, they get really good at doing the plans, and often I come in to the OR and they already have things planned. It might be tempting to not review your screws and all that, but you really have to carefully review all the trajectories. There are nuances that only the surgeon will know, and what you're thinking and what your plan is for the patient. So don't fall into that trap to just have your reps plan your screws and not pay attention to it. And I really like to check the skin incisions in the software for the MIS cases. I feel like this has helped me tweak things very minimally and not compromise on the placement of the screws, and get really nice results with incision sizes, and minimize tissue damage. And also the
Carlos,
second,
quick,
yeah, go ahead, Mike.
just quick question before you get too far ahead. You'd mentioned something about marketing, right? And this is something I hear from a lot of spine surgeons,
Yeah.
ortho neuro, that they want a robot for marketing purposes.
Yeah.
Like there was a guy in upstate New York who was in private practice who wanted a robot. They got a Mazor, and I heard it was collecting dust, right? And he only wanted it for marketing purposes. So like,
Yeah.
do patients actually come in and ask for robotic surgery? Like how does marketing work when you have a robot? I'm just curious.
Yeah. I think like now it's kind of like a widespread thing with robot everywhere. I see at the hospital advertises robot for this, robot for urology, robot for neurosurgery, robot for bronchoscopy. There's all sorts of robots around, and it's probably going to get more and more common. But we do have people that come and ask about it. I feel like here what has happened is that because we have this rural feel with the population here, a lot of people would go to the cities because they market very aggressively here in the area. So you have these private spine groups in Minneapolis, in the Twin Cities area, that will come here and do marketing, and say like, we do things minimally invasive, we use robotic technology, we do this and we do that, and people just bypass us here because they think we're more rudimentary or whatever, and go there. So this was part of this development of we have this minimally invasive program that works really well. We do have access to technology, to less invasive surgeries. You don't have to drive 2.5, 3 hours away to have your spine surgery done. So it was part of that, and there was marketing done in that sense, and it has been successful so far. And people do. Some people are weird out about the word robot. You have to tell them we still do most of the work. They get a little bit anxious about, oh, is a robot going to do the surgery? Then you explain to them, but it's as a way to, have more accuracy and safety, that kind of thing. Does that make sense? I don't know if that answered your question.
Yeah, no, it does. Just because every once in a while I have patients that come into clinic and they'll ask about, do you do the surgery robotically? Do you do
Mm-hmm.
I often get asked, you're going to do my operation laparoscopically. Obviously,
Mm-hmm.
they don't understand the difference between endoscopy laparoscopically, but I feel like that there's definitely an uptick more recently with patients having knowledge of some of the
Mm-hmm.
technology out there. They may not understand the nuances the way that
There,
we
yeah.
do, obviously, but there's a message getting out to them that there's increased technology that's on the market that may enhance the
There,
safety profile of their
mm-hmm.
surgery. And I think that's really where the marketing comes in handy, is that
Mm-hmm.
patients want to have safe surgery, right?
Yeah,
And if it means that putting your pedicle screws in with the robot is safer, that's what somebody wants.
Exactly. Yeah, exactly. And yeah, we, there's Dr. Google out there. Everybody checks Google nowadays when they have their problems. And um, if you Google, spine surgery in our area here, you get Google ads about, all sorts of private spine groups in Wisconsin and in Minneapolis, and they're very aggressive with the marketing. So it's kind of a weird, a little bit of a weird thing, but yeah, I think the way that I explain to my patients, at least, is that the robot is one extra piece of technology to help us do the surgery safely, and it's very accurate, and people do like that, and I think that's an honest way to describe to them. It's not like you have some crazy robot doing your surgery.
Right.
So let me check here. That okay, here we go. And just understanding the technology is really essential before you start doing the cases. There is some nuances to it. You want to know when not to use the robot reference frame and use a patient-based reference frame. And this is just this picture on the right side here just shows one of the points where you can do your accuracy check, but that's not the only thing that you should check. And then in terms of registration, we touched a little bit on that, Mike, the workflow. Like I said, for the elective cases, the vast majority of the patients will come on the morning of the surgery. They will get a preoperative CT. That gives us more than enough time to do the planning, and I do like that because that gives you a little bit of time to look at the software and really play around with it. And I think that's the main advantage of the pre-planning. But there are certain situations where you do want to use what we call the scan and plan, the O-arm. The O-arm is a bit more straightforward in terms of registration. You don't have to get the 2 X-ray shots to match the CT with the fluoro. But you have that at a time, and after you get the spin, you have to go there in the software and plan the screws. So then I don't know, feel like you have a little bit less time. And majority of the cases, you can do your connection with the chance screw, in the PSIS, and unless you're doing, thoracic case, and that you can use a spinous process clamp. Then the robot will do the topographical mapping, is basically a way for the arm to know if there's any obstruction in the way, and it will account for the towers if you're doing the case minimally invasive, so he knows what kind of movements he can or cannot do. And then you get your snapshot registration to match things with the stealth navigation. And if you're using the pre-op CT, you can see here in the C-arm, you have this image adapter here that is mounted. And this has, radiopaque beads there that will match with this carbon fiber extender that is over your target here, that you can roughly kind of guess, based on the anatomy. And then you can have your 2 X-rays and match the CT with the fluoro. And one of the things that I really like about the technology with the Mazor is that it looks at the vertebra individually, so it's segmenting and registering each vertebra individually. So if you have a patient, you got your pre-op CT in the prone position and they have a mobile spondy, the robot accounts really well for that. And you can see, I think I have a picture that shows a little bit of a dark wedge where there is movement, but the vertebra will be, the robot will be able to see the vertebra where it's supposed to be, for your planing for your screws. So even now when I do A-lift cases, the robot accounts really well for the added cage in the front, and you can still use the CT for placement of your screws. And obviously this is all fun and games until you have some issues. We did have a handful of issues with the registrations, not as much as you would think, for probably because my partners had done a bunch of these cases before I started doing. But main thing, we have now a protocol for the CTs, just basically a thin slice CT with cuts, 1 or 2 millimeters, and you want to make sure that that's adequate. I had two registration issues, and that's the picture in the middle here, because this image adapter was not mounted correctly. And this is, you manually mount that into the C-arm. The radiology tech does that, and it has to be hand tight. And if it's not exactly in the position that it's supposed to be, we found out, after some pain and suffering, that it was not allowing for the robot to register. In one of these cases, it just didn't register at all, which, okay, we didn't know exactly what was going on. And so we got an O-arm spin. And the other one was a bit more scary because this was a little bit off, and it did register, but the depth was off. So, and honestly, that was just, this didn't feel right. It was a little bit weird based on what I would expect, from the anatomy. So we double checked with X-rays and found out that that was wrong. So then also, went to the O-arm for re-registration. But now it's something that I kind of got paranoid with, and I just look at it and I ask my radiology tech if that's properly mounted, because something kind of really silly, but there's a human component there that can mess things up.
So, Carlos, if you
Yeah.
don't have the luxury, I'm calling it a luxury, but if you don't have the luxury of having done the case open where you can visually inspect your anatomy to match your baseline knowledge as to where a freehand screw would go, how are you accounting for these issues with registration when you're when you're utilizing a robot for PERT cases? Because obviously you're completely blind in those cases. You don't have your baseline anatomic knowledge to kind of be like a safe check, right?
Exactly. Yeah. I feel like, because I trained, and that because I trained with you, we did a lot of open case and freehanding screws and all that. I think this has saved me a couple times, because it's not what you expect. If you're freehanding a screw, you just know, like, that angle doesn't make sense, or this, there's something weird about it. And this is how I realized here in this situation. And in one of those cases, like I said, it was worse, because it would register, and it was basically showing on the screen something that it was not real. And you would probably only discover that after. And that's one of the things now that I learned, that if you have issues with your registration and you have to convert it to the scan and plan with the O-arm, you want to put something, if it's a minimally invasive case that you're not opening the patient, you want to put like a spinous process Casper pin, or like a spinal needle. You have something to double check, to almost get like an anatomical confirmation, so you can compare things to see if it makes sense. Almost like getting one of those pedicle markers, if you're trying to ask the interventional radiologist to help you localize a level in the thoracic spine. I've seen people do that, and it's sort of the same principle. It's an option, and if it's something that now, if I have to convert into an O-arm, and because we're having issues with registration now, I'm kind of paranoid, and I want to have something that I can use as a reference point. But yes, it's not a substitute for having the anatomy knowledge. And I also want to point that if you're having issues with registration, you might just want to change the reference frame. There is a robot-mounted reference frame that works very well for the vast majority of the cases. But if you're having issues with your registration, you might want to change that reference frame to patient-based, like a spinous process clamp or something like that, that can help with your double-checking your accuracy.
All right, I've got one more question. I don't want to ask too many in the middle of your talk, because this is
no,
fantastic.
that's good. I think this is the goal.
At the end of your case, how are you checking your screws? Like, are you doing another O-arm spin? Are you just checking with
Yeah.
fluoro? Are you stimming your
Mm-hmm.
screws? You know, the few times in my career that I've had to take a patient back to revise a screw, they've all, and it hasn't been many times, knock on wood, it's been about 2 or 3 times, but it's been cases that I've actually navigated. And
Mm-hmm.
2 of the 3 were perk fixation cases.
Mm-hmm.
And the accuracy was off. We got a, intraoperative x-ray, like, oh, we use nav, everything is probably fine.
Mm-hmm.
Then the patient would wake up and one of them had a radiculopathy, get a CT scan, there's a medial breach, right?
Yeah.
So what's kind of your safeguard in those situations? You doing an O-arm spin or just completely relying on x-ray and the fact that you use the robot?
Mm-hmm. If I have some concern, I will get an O-arm spin, but I always get x-rays right after I put the screws in, which, it might be a little bit too much, but I'm very careful with getting straight shots and seeing the pedicles. This has worked for me, over 99% of the times just fine. But I only realized those 3 misplaced screws after I got the C-arm X-rays. And so I put the screws with the robot, and then I bring the C-arm in, and I get an AP and a lateral shot. For the vast majority of the cases, that's enough. If I'm concerned, then I get a spin. But I also like to do that before I do my interbody fusion. That has prevented me from getting rid of the lead, and maybe doing these completely navigated. But I don't know, I'm just not there yet. I also use a lot of expendable cages. You can navigate those and get a simulation basically, but I still like to see that under fluoro. So, it's just one of those things like it's never going to be 100% accurate. So I think you have to check your screws before you get out of the OR at the very least. So other issues that you can have with registration, movement. We all know that same thing with the stealth. You really, if the pin moves and all that, it can be a problem. So I'm very careful with the pin placement. I like to just get a spinal needle and find. It's rare that we have a patient where we can feel very well. This is the PSIS here in northern Minnesota. So I do like to have my spinal needle and find that the appropriate bone, the sacral bone, is way too thin for that pin, especially after you place a few screws that will get loose, and it might cause you trouble. So you do want to make sure that you have a good fixation point. And obesity, if the patient is really, really large, you're going to increase the distance between the spine and where those points for the C-arm, the radiographic markers are. So that can be an issue that you have to pay attention to. I haven't had an issue with that in obese patients, but it's a case where you should go in with increased awareness, that you should pay more attention, maybe do more accuracy checks and be careful. Poor bone quality, mostly because you're depending on the CT scan. That's one of the things that I like about the pre-op CT, is a little bit better quality and you can see better. And in revision cases, the robot has that nice segmentation software to identify the vertebrae, but because it identifies them individually, if you have those large lateral metallic implants, you might not see the end plates very well, or if you have fused vertebrae, and you might have issues with the registration. I haven't had that happen to the point that we were not able to register, but then at that point it would be very difficult to use the robot. So probably something that you want to, in advance, if you see that preoperatively, you might want to think about not using the robot for that case and maybe just using the stealth. The main thing that with the robot, and that was the reason for it, all of the lateral screws that I had, is the skiving issue. So basically, the robot arm aligns with the trajectory, and then you're gonna make your skin incision. You're gonna use the sleeve with the dilator, and that sleeve, you have to be really, really careful where the sleeve is landing, especially patients that have degenerative facet joint hypertrophy. They're predisposed to the skiving. You want to make sure that you're not pushing your sleeve down against the bone. So I always like to touch the bone and have a feel, and then you look and make sure that things look accurate. I pull the sleeve up a little bit so he has some. It creates a little bit of a gap between the bone, and then you just use your drill. I use the high-speed drill to create your trajectory, and you want to get the drill started off the bone, and then just let the drill do the work. You don't want to be. The robot is really light touch surgery. You know, I know that we are all careful with that when we're using stealth, but here you really want to. Once you have that arm aligned with trajectory, you just want to be passing the instruments, you know, very smoothly. You don't want to be pushing down or forcing things too much, but you do have to be really, really careful with this sleeve so you don't push against the bone, and that can change your trajectory. And we have learned some ways to mitigate that risk. After about a year of using the robot, there was a software update. Is this picture here on the right side? This is, I think, an lift plan, but it introduced the ability to create these robotic, assisted facet cuts, let's say, where you can create cuts through the facet in your contralateral side if you're doing an MIST lift to get some sort of posterolateral fusion there. You can pack bone into that facet cut, and the tool that you use for that is this very rough-looking acorn drill. But I feel like the best use for this was actually not the reason that we introduced it was to create better landing points for the cannula. So now whenever we see, like, you know, a crazy arthritic facet joint, very cortical or very vertical, that you know that is going to have a skiving, elevated skiving risk, we just get a starting point. You know, you just drill 2-3 millimeters with this drill, and you create a much better landing point. And since we started doing that, none of us had another issue with skiving. It really helped mitigate that risk pretty well. So I would highly recommend using that tool if you're doing robotic cases, and really just based on preoperative anatomy. After you get a little bit of experience, you kind of know right away what kind of cases you have a risk of skiving, and this has been a great tool to prevent that from happening. And tissue pressure is something that you want to be careful with. You know, even in minimally invasive cases, there is this large blade that you pass down through the robotic arm. You want to make sure that there is no piece of fascia that is not cut properly that might push against your cannula, but is obviously something that is more relevant when you're doing an open case. But that's something that you got to make sure that your cannula goes in really smoothly, and you want to account for bony anatomy. You know, if you're putting screws in the lower spine or the sacrum, rarely the iliac crest can interfere with that, and you want to make sure that you look at that in your plan. And physical barriers, people that have lots of arthritis or posterior fusion mass, large, spinous process clamps, all sorts of things can get in the way of the cannula. You know, basically the bottom line is you just want to make sure that nothing really is touching that cannula, because that's where the accuracy comes from. And then, after you get your registration, you kind of ready to robot. It's not the best picture here, but I just took this in the OR last night, and these are kind of the basic tools that we use for the robot. I do like to use power for everything robot related. I feel like, because especially with the Mazor, you have that pin attached to the patient. You don't want to be, doing too much torque and moving the patient. So I know that there's an argument that you lose some of that tactile feedback, but there's different haptics that you get used to it too. You know, what you're looking in the screen and what you're hearing with the drill and what you're feeling with the drill. After you do enough of these cases, there's certainly some feedback that you get, and you should know what to expect. But there are different ways to do this. This is just a way that has worked well for me. So you have your chicken foot, and then you have your drill, which is a 30 millimeter drill, to create your starting point in the pedicle, and then you have your cannula with a dilator, and then you have the tap, and use the tap and the screwdriver with this battery operated drill. It's a slower much slower speed than the high speed Midas that you create your initial hole with. And this is just that long blade that you use for creating your stab incision. Although often, I'll show you guys a little bit later, when I do these MIST lifts, I use a pedicle-based distractor that works really well with the robot system, and you just basically make small Wilts incisions for that. So, the first cases that I started doing after seeing how the robot worked, I felt like percutaneous instrumentation of fractures is a great starting point for the robot. It's still one of my favorite cases to the robot. It works so well for that. For all of those cases, I do the O-arm scan and plan workflow. We see a lot of fractures because we're level 1 trauma center, and those patients, you really don't want to be moving them around and get another CT just for convenience. So just keep them in bed rest, and then also when you position them in the OR, that's one of the main parts of these surgeries. That's where a lot of the risk is with these thoracic fractures. You got to make sure your neuro monitoring looks good, your positioning looks good, and then I like to get a set of quick X-rays to make sure that the alignment is good. And then we get things going with the robot. One thing that I really don't like about this current part of this system with the robot is that the spinous process clamp is really, really bulky. Is this really big peak clamp? I don't know why it's so big. I make sure to always complain to my reps about it. So hopefully one day it would change. But you almost need 2-3 inches of incision just to get that clamp in. It's a little bit strange. And like I showed that picture with the facet cuts, it's not something that I do for all of these percutaneous fractures, but you can add facet cuts and pack bone into the facets across the fracture if you feel like that's appropriate. You have the ability to do that. So this is one of the cases that I did initially. It's a unstable fracture, a patient with ankylosed spine. You don't want to be moving him around to get another CT, so you just do a scan and plan. You can in these small thoracic pedicles, you can get really a good planning and optimize the trajectory of the screws, and planning then in an anatomical way does help quite a bit with getting a good reduction once you put your rods in. So that's a good starting point for the robot, I would say. I think it's a good place to start. You
Just out
say
of
you have something, Mike? Go ahead.
curiosity,
Yeah.
out of curiosity, how did you get that fracture, undistracted, for lack of a better
I
phrase?
know.
Like
I
when I
don't.
have these ankylosed spine
Mhm.
fractures, I feel like sometimes after I instrument them, the distraction of the ankylosed
Is
fracture actually looks
is
worse.
worse.
This
Yeah,
actually looks
exactly.
like 100 times better. How'd you
It,
do
wa-
that?
I think this was quite a bit of it was positioning. I think during the position this was just so mobile. It does tell you that how unstable these fractures are. I don't know if the guy, when he was getting his CT, just from him being supine, this looks so distracted like this. But once we position him, actually things look significantly better. And then after, planing the screws in a nice anatomical way, once you put the rods in, it really reduced nicely. So I was also, very happy with how this, but it doesn't always go like this.
Yeah,
I
that
had
looks
several of
awesome.
these. I know that looks
Curious
really,
what
yeah.
did you compress on it or anything? I guess it
I didn't
just
have to. No, I didn't
no,
have to do
maybe
any
it's
of
just
that. No.
self-reduced. Well,
Yeah.
take credit, man. Own it. It looks great.
Thank you. Thank you. Um, yeah, but that's, these percutaneous cases are great starting points. And then I started using like every opportunity that I had, I would use the robot. This was a patient that had a pathologic fracture after a treated infection. And so we did a lateral corpectomy. And, this is a stressful case. And you want to be really focusing on that complex part of the surgery. And having the robot for that it adds a little bit of peace of mind, knowing that you're going to have that tool to really get optimization of your thoracic screws. And this, I remember this case that I really had to tweak the screws a little bit to get around those really bulky bolts from the lateral plate, and it worked really nicely for that, and we got a good corrections. And this was I opened the patient from the back, because I wanted to get a little bit more postural lateral arthrodesis there. She didn't have great bone quality, but you basically can use the robot for all sorts of cases, and it has these advantages. In this case for me, it was just nice peace of mind, and we're able to plan the screws around the lateral plate bolts, and just focus on that most complex part of the surgery. And then
So
I also
I got a
go
quick
ahead.
question for you.
Mm-hmm.
So could you just go back to that picture again?
Yeah.
So I noticed that you put, lateral vertebral body screws in as well. It's a little bit off topic, but do you see any potential application for robotics in maybe situations with adolescent idiopathic scoliosis, whereby some surgeons are now using tethers as opposed to doing your standard, posterolateral
Mm-hmm.
fusion? Right.
Mm-hmm.
Do you know what I mean by that? So you could come in laterally, you place vertebral body screws rather than
Mm-hmm.
placing a rod. You're placing a tensioning device, right? Essentially, for
Mm-hmm.
lack of a better phrase, like a rope, right?
Uh-huh.
To try to correct
And
it. Do you see any application for robotics with spinal tethering for AIS?
mm-hmm. Honestly, not sure, Mike. Not. I don't know if people have used the robot for that. I feel like it's still like and this obviously they're doing through a lateral approach, right? You said. I think it's just not. I don't know
Yeah,
if
through a lateral approach.
will
Yeah,
probably be
it's usually done retropleural or it's usually
Mhm.
through a retropleural or retroperitoneal approach.
A few updates from getting to that point. I think it just depends so much on nothing moving and all that. I don't know if I would feel super comfortable with that. Then after I've done a few of these percutaneous fractures, I started doing MIST lifts with that. Not something that I had a lot of experience with in residency, and I have used the Space D retractors. They're pedicle-based retractors. I think I have a couple of pictures of that, and with a microscope, and it works. It works really nicely for that. You can really minimize the incision size, and it's nice to know exactly where your screws will be, and then you just it's very straightforward case to do with the robot. And this is how that Space D retractor looks like. It goes over the screw towers, and you have these small Wilts incisions, and it has a medial blade that I usually like to put right above the spinal laminar junction if I want to get over the top decompression and the contralateral recess. And by playing with the bed and playing with the microscope, you can really get very nice decompressions with this system. And there's also lateral blade that you can attach to it if there's too much soft tissue in the way, but I rarely use that. It's usually not something that really gets in the way much. You have the option to pass your rods through this system, or you can just remove your retractor and put the rods the usual way. But it works really nicely with the robot, and tweaking your plan makes your life really straightforward with these decompressions. You can see everything, exactly where you are. I don't use a lot of the navigation during the decompression with the microscope. It really gets in the way. But after you get your screws exactly where you want them, and you confirm that matches with the plan with the robot, I like to look at that AP X-ray, and you see that it looks exactly like the AP plan in the robot. Then you kind of have your navigation there. You just do a quick decompression, do your T-lift, and then I'm very happy with how this has worked. I do a lot of most of these with expandable cages. You can get decent size cages in and good corrections, and now you have this, a minimally invasive T-lift. you have to do a good discectomy and a good interbody fusion. That's really where you're getting your fusion. So these facet cuts, it's not a replacement for that, but it is nice in the contralateral side where from your facetectomy to add that and pack some bone. Often I would be trying to like expose the bone in between at the end of the case, and you're causing more bleeding than anything with a matchstick, and trying to bury those facets and pack some bone there. So this has made this process much more smooth, and it's a nice addition, but not a replacement for a good interbody fusion. And like we talk a little bit about that, but I always check after I put the screws, but you want to always check your hardware before leaving the OR. And I still haven't completely trusted the either navigation or the robot to just do everything and leave the OR and not get an X-ray to see how it looks. Maybe one day we'll get to that point, but I think it's just you don't want to have a reoperation, even if it's one. It really doesn't add much for you to check. And this is technology. It's not perfect, but it can be very accurate, but it's never going to be 100%. And then I now use the robot after I do my ALIF. I used to do the ALIF and then see if the patient would get better, and then decide if I would just put percutaneous screws or do a decompression from the back. I now rely more, I trust more, I guess, in the indirect decompression. And but if I feel like the patient has a lot of facet arthritis and he needs a decompression from the back, that Space D system, it's very straightforward. You can do a quick decompression, 20, 25 minutes and have peace of mind and not have the patient come back for another anesthetic. And our nurses have gotten really good turning over the room with the beds and flipping the patient. So I just like to do this all on the same day now, and the robot works really nice for that. And I think we talked a little bit before, Mike, but open surgery, I think there is a lot of room for using the robot. The main thing here is the tissue pressure, like we discussed. You really want to make sure that those paraspinal muscles are not pushing against your cannula. Worst case scenario, you can do transfascial screws, but ideally you just get whatever exposure you need to not have tissue pressure against the cannula. If there is no tissue pressure, it will be accurate. It will work well, and it can help you minimize, some of the distal and proximal dissection. You can be sure to spare the facet in your upper instrumented level and the interspinous ligament. Maybe that's a way to prevent BJK. You get more predictable rods. We went over that. This is, just how that unit platform looks like. I have used these a few times for the T10 pelvis to get pre-bend rods, but I don't know if it's something that would be very useful for a lot of the more complex deformity cases. And the robot, if you're using that PSIS pin, the limitation, according to the manufacturer, is L4 level. So depending on your patient size, and after you experience with it, you understand the limitations of it. You can get more than that. But I would recommend initially just change your bone fixation point. It's the safest thing to do. And you just re-register quickly, and then you can get your top screws. You don't want to be too far away from that reference point, because that's when you're going to have issues with your accuracy. And I think, I did a couple of single position O-lifts. I can't say that I loved it with the robot. Obviously, we're still kind of learning, but it really limits like the angle of those, let's say, bottom screws, the ones that are close to the bed. I feel like I've seen people doing these prone lateral surgeries with the robot. Seems to be a more natural thing for the robot to do. So we'll see it, but I think this is kind of my goal, to introduce more of these in my next 100 cases and see how things go from there. And I think we talked a little bit about this, Mike, in private, but robotics in training, I don't know. I have mixed feelings knowing, coming from training where we did mostly freehanding and I think we only had no arm for the last 2 or 3 years of training. There's a learning curve, of freehanding screws, and I think that's really invaluable. But I know that eventually, people will incorporate this in their practices. If you're in an academic setting, you're gonna have to, I guess, be creative. With the navigation, with the stealth, you still have that ability to maybe have your resident freehanded screw, and you're looking at the screen and guiding things a little bit. With a robot, you don't have a lot of that, so you probably have to embrace more simulation and things like that. But I don't, I really don't have any regrets of not having a lot of exposure. I think the incorporating this to practice, it wasn't really terrible. It was pretty straightforward. And having that knowledge of the anatomy was actually really good, because that gave me the peace of mind to be able to adapt this new technology into my practice. Because certainly, it facilitates, streamlines. Definitely, it's an amazing tool. But training wise, I guess it's something that we have to figure out how to incorporate this into residence training.
Carlos, that was fantastic. Thank you so much for this very thoughtful talk that you just gave. I'm sure this is going to end up being a great reference for many of us out there. I'm sure if and when we ever end up getting a robot at UNC, I'll definitely reference this talk again, because you've obviously got a pretty robust experience with it. I'm curious what you think some future applications are for robotic technology. You really focus mostly on thoracic and lumbar cases. Are you ever using it for cervical fractures or cervical deformity? Talk to me a little bit about the applications for like C1 lateral mass, C2 pedicle screws, or are we not quite there?
I know that some people have used it, and I think it's the Globus robot. We have one of our casual guys here actually that uses it in his private practice. I don't know how I feel about that. I think that there's so much mobility in the cervical spine, especially if you're talking about trauma cases and things like that. I don't know how comfortable I would be, because this is very sensitive to any movement, and I think we'd all have had cases where you're doing a cervical fracture with navigation, and even after you put a couple screws, you notice that the navigation is not as accurate anymore. Just minimal movement really changes things, and the cervical spine is really prone to that. So I'm curious to see how people are going to get to the point of this being so reproducible, and reliable, like it is in the thoracic and the lumbar spine. But I mean, it would be interesting. I saw, I think recently, a paper that they had this cannula that kind of docked in the bone with teats, and it was like a better docking point, I guess, but for lateral mass screws. But I don't know. I think having used the robot for quite a few cases now, I feel super comfortable with using the cervical spine anytime soon. I'll probably wait and see what other people do first to see how it goes. It's just too much mobility, I think.
Yeah, I think our previous co-resident, Dr. Hoon Choi, uses the competitor to what you use, and he has used it for some applications for C2 pedicle, C1 lateral mass screws, and kind of things along those lines. It's really fascinating to see where this is going to end up going in the next few years, and really where robotics in general is going to go. There was a talk about a year or so ago on this platform that a friend of mine, Ori Barzilay, gave. He's a spinal oncology surgeon from Memorial Sloan Kettering in New York City, and he spoke a fair amount about actually utilizing the Da Vinci robot for spine surgery, specifically for cases where patients may need to have a large retropleural schwannoma resected or things along those lines. So it's really fascinating to see where robotics will take us, not just in regards to placing pedicle screws, but also for other applications in spine surgery over the next 2 years or so.
Exactly. Or robotics in spine, it basically is just a robotic arm right now. It's not really like those Da Vinci robots, that fancy stuff. I think there was that neurosurgical focus issue recently. It's just about robotics and neurosurgery in general, and there's some good papers in spine. I think there was one that shows an autonomous laminectomy by a robot. So there's a lot of room here. I'm sure we're going to see some really crazy stuff with robotics in spine surgery. It's exciting for sure, but
Absolutely. All right. Well, I think our time's up, Carlos. It was fantastic watching you give this lecture. Really, really excited to see what the future holds for robotics and how your career is going to shape up in the next 5 or 10 years. So it's really exciting to see. And I believe that we do not have virtual spine next week as it's a holiday. So I hope everyone has a wonderful holiday season. And just check LinkedIn and Twitter/X, and we'll let you guys know what the upcoming lecture is going to be in the next couple of weeks. So have a great holiday, guys. Carlos, awesome seeing you.
Thank you, Mike.
Give my best to your family, and we'll talk soon.
You too. Thank you so much.
All right, guys. Take care. Bye.